Alright guys, this is Dr. Manish Chhabra, your ophthalmology educator at PrepLadder. I'm going to discuss the one-liners in ophthalmology and you may read it as mission impossible. ध्यान से देखो, it is mission, it's possible. It is very much possible to crack the single liner MCQs, which are mostly rote learning based. But I have compiled all the one-liner questions and going to discuss in this very session, and you will see that at the end of the session you are easily able to remember every possible MCQ. Okay, so starting with the very first slide, so let's begin. So can you tell me which is the thinnest wall of the orbit? Thinnest wall of the orbit is medial wall, your previous year question. And the bone which is there, which is actually forming the thinnest wall, because this is the thinnest wall, that is your lamina papyracea. You know that lamina papyracea, which is actually the ethmoid bone. Lamina means layer, papyracea means paper-like. Now can you tell me the thickest and strongest wall of the orbit? That is your lateral wall, and that is because of the zygomatic bone. Now next is, what is the weakest point of the orbit? If you will carefully see, what is this? This is your teardrop sign. The image has been asked multiple times in your previous year question. You can appreciate that there is a teardrop sign which is due to herniation of intraorbital contents of the orbit, and that happens in blunt trauma. When there is blunt trauma, there is rupturing of, or should I say there is fracture of the inferior wall of the orbit, which leads to herniation of intraorbital contents, and which you see on X-ray as teardrop sign. And it is the most common wall which is inferior wall or posterior-medial wall which is fractured. All right, coming over to the next slide. Now can you differentiate between the superior orbital fissure syndrome and orbital apex syndrome? Mind you, orbital apex is superior orbital fissure plus optic canal, and superior orbital fissure syndrome is only superior orbital fissure. Now if you want to differentiate, so you should have a clinical anatomical knowledge. Now which structure passes through the optic canal, which is a part of orbital apex but not the part of superior orbital fissure syndrome? That is your optic nerve. Now if there is loss of vision, it will tell you that okay, there is involvement of complete orbital apex, which is superior orbital fissure, as well as optic canal, so there will be loss of vision. But now moving over to the second one-liner question asked from this topic, orbital cellulitis and preseptal cellulitis. So most common organism is, that is your Staph aureus. Okay, now most deadly complication of orbital cellulitis. Now what happens is, there is raised intraorbital pressure. So this is your orbit, this is your eyeball, so there is septum all 360 degree. When there is raised intraorbital pressure due to inflammation posterior to the septum leading to orbital cellulitis, it compresses upon all the structures which are present inside the orbit. And boys and girls, there is artery which is compressed, but there is vein which is also compressed. Vein, being a low pressure channel, is compressed more, and wherever in the body if there is stasis of blood, it leads to the formation of microthrombi. And boys and girls, those microthrombi got lodged in this cavernous sinus, leading to your answer to the next question. Most deadly complication of orbital cellulitis is cavernous sinus thrombosis. Now if one cavernous sinus is involved, you are suspicious whether there is also the involvement of the other cavernous sinus, because you know both cavernous sinus are in contact with each other. So one is get MRI done, but you know we are living in a country where we are nearly 80 crore of the population which is dependent on the free ration by the government. So you cannot actually write MRI to every other person in which you are suspicious of the involvement of cavernous sinus in orbital cellulitis, yes, of the other side. So what you are going to do, you will apply your clinical knowledge, you will apply your clinical acumen. So your clinical acumen says that this is your cavernous sinus. There is passage of one nerve. Which is this nerve? This is abducent nerve. There is passage of abducent nerve from the center of cavernous sinus. Right? Now if there is involvement of the other side of cavernous sinus, the nerve which is passing not through the lateral wall, these are the nerves passing through the lateral wall of cavernous sinus. The nerves which are passing through the center of cavernous sinus is going to get involved first. So that is your abducens nerve. But abducens nerve supplies which muscle? It supplies lateral rectus muscle. So if there is damage to the abducens nerve, if there is involvement of the other side of cavernous sinus, so it will affect the lateral rectus as well. So if you will ask the patient to abduct the eyeball, if lateral rectus involvement is there, the eye will not be abducted. So there will be typical abduction defect. There will be typical abduction defect. So that is one clinical acumen application by which you can save nearly 10, 12, 15,000 rupees of that of the patient, and you know whether there is involvement of the other side in cavernous sinus involvement or not. All right. Now moving on to the next part. Can you tell me the treatment of orbital cellulitis? I always say, if you know the etiology, you know the treatment. If you know the pathogenesis, you know signs and symptoms. What is the etiology? It is the most common organism, bacterial, Staph aureus. Yes. So what will you give as a treatment of orbital cellulitis, boys and girls? You will give the drug which is effective against Staph aureus. And what are those drugs? It is IV, intravenous, vancomycin, and third generation cephalosporin. That is your treatment of choice. In orbital cellulitis, you can also top it up with metronidazole, which is effective against anaerobic organisms. All right. Now, coming over to thyroid eye disease. Now, most common cause of unilateral and bilateral proptosis in adults, it is thyroid eye disease. Now, if we are talking of adults, it is also important to read about children. Most common unilateral cause of proptosis in children, it is orbital cellulitis. Most common bilateral cause of proptosis in children, it is neuroblastoma. देख लेते हैं. It is neuroblastoma. Is it understandable? All these are your PYQs. You cannot afford to miss these questions, and it is our responsibility at PrepLadder to make sure that you get 15 out of 15 in ophthalmology. Not only in ophthalmology, our vision is to help you crack nearly 100% of the paper. So that is the idea of conducting these rapid revision sessions, right? All right. Now going over to the next slide. So can you tell me the earliest sign in thyroid eye disease? I know most of you would answer, sir, it is proptosis. No, boys and girls, it is not proptosis. It is Dalrymple sign. Dalrymple sign is due to stimulation by sympathetic fibers of that of the Muller's muscle. There is upper eyelid retraction. That is your Dalrymple sign. Second sign, which is important for you to know, first is most common. Now the second sign which is most important for you to know is lid lag in down gaze. You are asking the patient to look in down gaze, and you will appreciate that where there is proptosis, the eyelid will not go fully down. That is your von Graffe sign. Von Graffe sign. And here you can appreciate that there is what? There is upper eyelid retraction of both the eyes. Okay, that is Dalrymple sign. Now, what is the force duction test? First, let me write and then I'll explain you. Force duction test is, you are confused. So, suppose the patient has come to you with right hypotropia. Now, there can be two reasons for right hypotropia. One is that there is superior rectus paralysis, due to which the inferior rectus has taken the eyeball below. Yes. Second is the inferior rectus is holding the eyeball and not allowing the eyeball to go where? To go upwards. So you are confused. So what you are going to do? You will take the eye, means you will ask the patient to sit. You will hold the eye with the limbs forceps on the superior conjunctiva if there is right hypotropia, and you will simply try to move the eyeball upwards. If there is movement of the eyeball upwards on forcefully moving it, force duction test na, so that means it was because of the superior rectus paralysis. If there is no movement even on forcefully trying to move it upwards, that tells you that something is holding the eyeball from below, and boys and girls, that is your inferior rectus fibrosis. So that is why I have told you that it helps in differentiate between paralytic and restrictive squint. Okay, now to assess the amount of proptosis, what instruments are you going to use? Proptosis is protrusion of the eyeball. Now, when we talk about proptosis in thyroid eye disease, we call it as exophthalmos, both are absolutely the same. We call it as exophthalmos, both are absolutely the same. Now, if we want to assess the proptosis, mind you, quantitative assessment, not qualitative. Qualitative, we have Nav-Ziegler test. If you are doing it from back, we have worm's eye view. If you are doing with, with your view from the front. But if you quantitatively want to assess whether there is presence of proptosis, yes or no, then you will use an exophthalmometer, and that is your Hertel's exophthalmometer. If you want to assess proptosis in adults, but if in children, that is Ludi's exophthalmometer. Yes. Now, when do you call that the patient has got proptosis? When the distance of the center of the cornea from lateral orbital rim, yes, from lateral orbital rim, when it is 21 millimeter or more, then you are going to say that, okay, this patient has got proptosis. So this is your exophthalmometer. Which exophthalmometer? Hertel's exophthalmometer. All right. Now, if we are talking of proptosis, so let's also know about intermittent proptosis. Your recently asked question. Intermittent proptosis is proptosis which is present for some time while it is present. It is absent at some other time. So that is seen in your orbital varices when the patient lies in prone position. So the blood gets collected posteriorly, which pushes the eyeball, so the patient is having proptosis. But when the patient lies supine, so blood gets drained due to effect of gravity and the eyeball goes back in the orbit. That is your orbital varices. Understood? Next is pulsatile proptosis. If there is to and fro movement of the eyeball, right? Especially seen in carotid cavernous fistula, and in your regular lectures I have shown you my one patient with pulsatile proptosis. Okay, so the answer is carotid cavernous fistula. If there is fracture roof of the orbit, if there is sphenoid dysplasia, it can also lead to pulsatile proptosis. Okay, and why neurofibromatosis? Because in neurofibromatosis there is sphenoid dysplasia. That is why I mentioned this disease, because this was also asked in your previous year exam. Okay, now can you tell me the most common tumors? And if I talk about most common tumors, first, most common tumor in children, most common tumor in adults. And I am talking of intraorbital tumor which is present between the eyeball and the orbit, or should I say present inside the orbit. All right, now most common benign, so benign tumors can be there, malignant tumors can be there. Most common benign intraorbital tumor in children is dermoid cyst. Most common benign intraorbital tumor in adults is cavernous or capillary hemangioma. Done. Most common malignant intraorbital tumor in children is rhabdomyosarcoma. In adults is non-Hodgkin's lymphoma or the metastasis from some remote site in the body. So let's just quickly write dermoid cyst, yes, rhabdomyosarcoma, which will be Desmin positive, then cavernous capillary hemangioma and metastasis. Now, if we are talking of the most common intraorbital tumor, let's also just touch the most common intraocular tumor, means inside the eyeball. In adults, it is choroidal melanoma or malignant melanoma. In children, it is retinoblastoma. In children, it is retinoblastoma. Now, okay, let's switch over to our second chapter, which is that of lens and its disease. Now, whenever we ask the patient to read the letters on the Snellen chart, which are placed at the distance of 6 meters from the patient. Now, there are different senses of vision. The most important sense which is involved in interpreting the letters, I am able to read the letters now because I understand the form of the letters. So, boys and girls, that will be your form sense. That will be your form sense. And there are different definitions, different forms of blindness. The most commonly asked question is that of social blindness. So when we say that the patient is having low vision, that actually means that the patient's vision is 6/18 to 6/60. Economic blindness less than 6/60 to 3/60. Social blindness less than 3/60 to 1/60. This is your PYQ, and here the answer will be less than 3/60 to 1/60. So that is your social blindness, and manifest blindness is when the vision of the patient is less than 1/60, and absolute blindness is that the patient is not able to perceive even the light. PL will be negative. Okay. Now, can you tell me the magnification of direct and indirect ophthalmoscopy? Direct ophthalmoscopy, the magnification is 15x, 15x. Indirect ophthalmoscopy, the magnification is 3 to 5x. All right. Now, can you tell me the most common cause of blindness? First question. Preventable blindness. Second question. In the world, it is cataract. Second most common cause of blindness in the world is, just telling you here, it is cataract, but just telling you one step ahead, it is glaucoma. Third is ARMD. Fourth is trachoma. Fifth is onchocerciasis. But here, PYQ, preventable blindness, if it is asked, or overall blindness, it will be cataract. But if I may ask you, which is the most common cause of blindness in children, that will be your vitamin A deficiency. Yes, let's move on. Vitamin A deficiency. Okay. All right. Now, next, which is the most common congenital cataract? Most common congenital cataract is your blue dot cataract. Can you appreciate these dots? No, these dots are not blue in color, they are white in color. But when you are asking the patient to rest his chin on the slit lamp, and you are seeing from the front, and you are focusing the slit beam from one side, the light is going to strike the white opacities, which are nothing but precipitation of insoluble proteins. When the reflected light will come, so it will give an appearance of blue color. You call it as blue dot cataract. But mind you, it is not associated with loss of vision. But can you tell me one cataract congenital which is associated loss of vision? Boys and girls, that is your lamellar or zonular cataract. Lamellar or zonular cataract. Here you would see that there is entire opacity in one zone, hence the name zonular cataract. And can you tell me which part of the lens is involved? It is your fetal nucleus which is involved. You know, from inside to outside there is embryonic nucleus 0 to 3 months, fetal nucleus 3 to 8 months, infantile nucleus 8 months to puberty, adult nucleus puberty to adulthood, and peripheral to the nucleus there is cortex. All right. Now, can you tell me most common cause of metabolic cataract? It is diabetic mellitus. Now, you can appreciate that this is something very known, very familiar to you. If you will open your WhatsApp, not right now. Right now, you are attending my class. I don't want you to get distracted. Hai na? If you will open your WhatsApp later, you will type snow and you will see something like this. Yes, icon like this. So this is your typical snowflake cataract. Now this snowflake cataract is the most specific cataract seen in diabetes. Rather, most specific cataract seen in type 1 diabetic mellitus. Okay. All right. This is your type 1 diabetic mellitus snowflake cataract. Now, if I may ask you, overall, can you tell me which is the most common cataract seen in diabetic mellitus? That is your early senile cataract. And which is the most common cataract seen in diabetic mellitus? That will also be early senile cataract. 2 extra points, because overall type 2 diabetic mellitus is more common than type 1 diabetic mellitus. Now your next PYQ, can you tell me which is the cataract associated with Wilson's disease? And that is your sunflower cataract also. Please remember, the cataract which is associated with chalcosis. Chalcosis is copper foreign body in the eye. That will also lead to your sunflower cataract. Now if we are talking of copper related to eye, so there is one ring which is deposition of the copper in the Descemet's membrane of the cornea at the periphery. In boys and girls, that is your KF ring. There is deposition of the copper at the periphery of the cornea, and periphery of the cornea is Descemet's membrane. Okay, now check this out. I am going to tell you a short story. So there was a Valentine's Day, and you know today's generation, Gen Z. So the guy liked the girl. So the guy thought, why not to propose his so-called girlfriend, when the girl was like, I like you, but as a friend. So the boy went to the girl with rose in his hand. He bent on his knee to propose the girl, but the girl who liked him but as a friend got so angry, she slapped boy so hard that the rose that he was carrying got stuck into his eyes. So slapping is which form of trauma? It is your blunt trauma. And rose getting stuck in the eyes, which form of cataract? This is, boys and girls, your rosette cataract. I hope I have not given you any post-traumatic stress disorder, right? Yes, that was not my intention.